we're going to get started. We're going to be talking and doing a small talk on endocrine case and endocrine issues. So first, we're going to open up with the case. We have a 67-year-old male. He has a history of hypertension, diabetes, CHF with a reduced EF. He's presenting to the ED for a cough, shortness of breath, generalized weakness. He is triaged to CCT. His vital signs are as follows. His temperature is 36. His heart rate is 105. Respiratory rate is 26. He is hypotensive, 80/47, with a MAP of 58. You're looking at him. He's ill appearing. He's in moderate respiratory distress. As far as lung sounds, they're decreased at the bases. You do a POCUS. He's got some occasional B lines. Doesn't appear to be fluid overloaded. A-line predominant. His IVC is not plethoric. Eventually, we get a chest X-ray. We find out that he has basically bilateral pneumonias. He has a white count of 21. He's got a left shift. His BNP and trope are unremarkable. Let's see. What else or what next are you doing for this patient? He's still hypotensive. Yeah, so we got fluids, antibiotics, still hypotensive though. He might. Right. So you're doing all of your interventions. You give IV fluids, antibiotics, you start peripheral pressors, you even place a central line. He's admitted to MICU, he's still boarding in CCT. The nurse keeps asking you, hey, his blood pressure, his MAP is this. It keeps going down. It's 55. So what do you do? Right. So this is the question. Steroids or no steroids? So we're looking at an article. This is from the Society of Critical Care Medicine. This is basically an update of the 2017 guidelines on critical illness and critical illness-related corticosteroid insufficiency. So basically, the goal of this study was to develop evidence-based recommendations for the use of corticosteroids in hospitalized adults and children with sepsis, ARDS, and community-acquired pneumonia. So first, they created a panel. They had a 22-member panel comprised of adult and pediatric intensivists, pulmonologists, endocrinologists, pharmacists, and then they also had some clinician methodologists. They looked at 3 separate outcomes: sepsis, ARDS, and CAP. And then they analyzed previously existing systematic reviews using a software called Covident. They basically generated 5 PICO questions related to all of these outcomes. The first 2 were related specifically to sepsis, most basic one being, should corticosteroids be administered to hospitalized patients with sepsis? And then kind of the follow-up question, if we're going to administer corticosteroids, should they be high dose and short duration or kind of low dose and long duration? Then it can ask similar questions about ARDS, corticosteroids versus no corticosteroids. And then they wanted to compare methylprednisolone to other corticosteroids in patients with ARDS. And then lastly, they kind of asked the same question regarding CAP. Should we do corticosteroids with patients with CAP? So we're going to just start with sepsis. So we're just phrasing it in a kind of our PICO framework. They're looking at all children and pediatric patients for all of these studies. The intervention, corticosteroids versus placebo. And then this is also the low dose long duration versus high dose short duration, comparing these 2. So what did they find? So they basically framed all of their recommendations using kind of the grade framework. They suggested administering corticosteroids for adult patients with septic shock. Essentially, they looked at 46 randomized controlled trials comparing corticosteroids to placebo. And the results of this show that there are high rates of shock reversal with a relative ratio of 1.24 and confidence interval of 1.11 to 1.38. So very high certainty in terms of shock reversal. They said it probably reduces ICU and short-term mortality. The relative risk ratio was 0.93. But the data on hospital and long-term mortality was less convincing. And then in terms of looking at high dose, short duration, they actually recommended against the administration of high dose, short duration of corticosteroids. I guess the dose that they used was greater than 400 milligrams a day of hydrocortisone equivalent for less than 3 days. They said this is like a moderate certainty of evidence. The reason for that being it showed actually somewhat of a increase in short-term mortality. Kind of continuing on, they looked at kind of the same thing for ARDS. Again, placebo versus no corticosteroids. And then comparing methylprednisolone to dexamethasone and hydrocortisone. And for this one, they do have a conditional recommendation of administering corticosteroids to adult hospitalized patients with ARDS. They use 18 randomized controlled trials and essentially saw that patients who received corticosteroids had higher rate of survival than those who received no or low dose. As far as the second PICO question, comparing methylprednisolone to other steroids, based on their subgroup analysis, they didn't demonstrate any credible like subgroup effects. So it seems like from what they could see, all of the steroids essentially were not having any significant statistical difference. For community-acquired pneumonia, again, same thing. They were comparing methylprednisolone to dexamethasone and hydrocortisone. And they also were kind of looking at whether or not this would be helpful for regular, I guess, community-acquired pneumonia versus severe community-acquired pneumonia. And as far as this was concerned, they recommended corticosteroids to adult patients that are hospitalized with severe bacterial community-acquired pneumonia. They showed that if you had severe community-acquired pneumonia, and they define that as requiring pressors, requiring any forms of supplemental oxygenation greater than like a nasal cannula. And they also had other measurements of community-acquired pneumonia. They have like a pneumonia scale that in these patients with more severe community-acquired pneumonia, corticosteroids reduce hospital mortality with a relative risk reduction of 0.62. But the effect was not actually seen in less severe community-acquired pneumonia. And so for that, they made no recommendations. One of the other things about this study is that although they set out to look at the effects on both children and adults, and they even included pediatric intensivists in their panel, they were unable to make any recommendations for children regarding sepsis, ARDS, or community-acquired pneumonia due to the limited quality of data. So if after this, you're maybe a little bit more convinced that potentially you would give corticosteroids in a patient with either severe community-acquired pneumonia or sepsis or ARDS, these are some of the dosing strategies that the study looked at. The study didn't necessarily recommend any of these strategies more than any other one, but these were some of the ones that they found that were used in the studies that they looked at in their meta-analysis. So for septic shock, we won't go into the ones that are greater than 72 hours, but they had looked at studies that showed using hydrocortisone 200 milligrams IV per day, Q6, or I'm sorry, divided every 6 hours as kind of one of the doses. And then for ARDS, dexamethasone 20 milligrams IV daily. We won't get into the weeds of this, but this is just something to consider. The study also looked at some of the side effects of steroids in the acute setting, right? We all know about moon phases and, thinning of your skin, things that happen in kind of longer term corticosteroid use. So one of the most common effects that they saw was hyperglycemia. They didn't think that this was something, I guess, that warranted not using corticosteroids. This is obviously something that we can manage. Neuromuscular weakness, it was something that they said was a patient-centered outcome that they were quite concerned about. Hypernatremia, neuropsychiatric effects, and then much less research or study or less evidence was GI bleed. However, they said adverse effects were defined variably across studies, and then their true impacts on patients were unclear just because they weren't really well defined in each study. So just something to consider, I guess, on the opposite end. And then kind of just the last part was, I guess, going to open it up to attendings and also maybe to senior residents. I don't feel like we use steroids really very much, kind of in the acute setting. I was just wondering, kind of based on the recommendations that potentially we should be using it more in these critical ill patients. How do you think that any of this kind of affects or maybe would impact or influence your management?
I've been trying to change my practice. I just don't see these like really sick community acquired pneumonia patients. There's like a Cape Cod study last year that informed a lot of the recommendations here. They pretty strongly show the mortality difference. So I want to.
Yeah.
I haven't seen the caveat now is we're seeing a lot of influenza pneumonia, and even in the Cape Cod trial, that was part of the exclusion criteria because that steroids have shown a preponderance towards mortality. And so I think just like what we're seeing right now, on the point where we're not really seeing a lot of like bacterial, we're seeing a lot of like super exposed bacterial pneumonia and setting of flu. But for them, I don't know if we have like a great answer, like if this is referencing that population. But I think they would end up getting excluded because it all started with their flu pneumonia. So
I mean, it's definitely something I incorporate like as a secondary. It's it's the initial management of sepsis care, airway management, respiratory care. If it's not improving, it's kind of a secondary diagnostic regarding what else kind of really on my for us. And I think a lot of times it gets incorporated probably on the ICU level too, when the people not responding to that. I mean, it's interesting to think about 5 years ago, we were using steroids on everybody. Maybe 4 years ago, more like it, for every kind of respiratory presentation and possible pneumonia. So it's definitely, I think, something that we have that it's usually a secondary kind of problem.
Yeah, like anytime we're going to add a second pressor, I think we should be now considering first access, right? If we know that that's really what the problem is, because we should be considering getting some support. And that's what I've been doing. I don't lead with it unless I really suspect it, but if I have that first pressor, it seems like we're just titrating it up. But okay, maybe I should add a steroid because most people for that second pressor.
All right. And these are my sources.